Good evening, everyone, once again, and I would like to thank you all for joining in. It's always refreshing to see each and everyone come for such initiatives, psychiatrists, trainees, and colleagues who are passionate about understanding the brain and behavior. So tonight, we kick off the first of 3 sessions this week. That is in our Neurotorium peer-led training to enhance neuroscience knowledge in Ugandan psychiatrists and trainees. And the theme this week is depression, which is a topic we all encounter often, and yet one that still continues to challenge and fascinate all of us. So before we dive into the discussion, I'm going to first invite our principal investigator, that is Dr. Emmanuel Mwesiga, to share a few words with us about the Neurotorium initiative and the current project that is being run. And after that, we are going to have our key discussant, that is Dr. Katama Sadat, who will take us through today's focus and therefore set the stage for clinical and therapeutic discussions that will follow in the sessions tomorrow and Thursday. So please stay engaged. Feel free to post questions or reflections in the chat as we go. During the question and answer session, we encourage you to put up your hand, and certainly the host will allow you to unmute yourself. So towards still the end of the question and answer session, we are going to display a short poll that we would really appreciate if you gave your feedback, because it will help us to improve each and every session. So once again, we thank you all for being here. Let us learn, let us share, and let us keep growing together. Dr. Mwesiga, over to you.
Okay, thank you, everyone. I'm Dr. Emmanuel Kiza Mwesiga. I'm a psychiatrist and senior lecturer at Makerere University. And I'm the PI on this project, peer-led training to enhance neuroscience knowledge among Ugandan psychiatrists and trainees. So I'm not going to say much. I just want to give you a brief overview of what we are going to do over the next 6 weeks. So that Dr. Muyanga and 3 other trainees maybe a year ago reached out to me and brought an idea. We all know the challenges of training that is going on in universities across the region. And the idea was that, well, since you've trained us, what would happen if you allowed us to train other people? So we then thought it was a good idea and applied for funding to, let's see if I can move the slides. Yes, to Neurotorium. I just need to, are my slides still shareable or they are not?
Yeah, shareable, can't see them.
Okay, I can't see them myself, so. Okay, so we asked Neurotorium. Neurotorium is just a it's like a training foundation for Lundbeck Foundation, and it's a non-commercial philanthropic free online resource. And their idea is that they want to enhance knowledge for neurology and psychiatry. And they have resources. They are free educational materials. I'll show them to you at the end of these 5 slides that are regularly updated, and they are on key disorders that you commonly see in neurology and psychiatry. So as I said, we know the challenges of training across Africa. So for example, in Uganda, there are 81 psychiatrists for a population of 52 million, with more than 10 universities. So being able to train undergrads, train postgrads needs sort of like a rethink. So our idea is that we can use the Neurotorium resources and peer-led trainers to train other people. So there are a lot of things that the resources have, and I'm going to show them to you. But specifically for students, you will find One, you spend a lot of time making slides. Neurotorium resources allow you to download slides as long as you don't plagiarize them. And there's nothing wrong with downloading slides and saying, actually, I've gotten slides from Neurotorium to make my presentation on schizophrenia, right? So that's a very key thing. Two, they're constantly updated with new information. Actually, one of the things we are trying to think about is, well, some of the drugs they mention in the slides are too new for us. Maybe we are still on first generation and earlier second generations, and how we can work around that. And there's a lot of content, there's a newsletter, there's history. So basically you can get a lot of information from these slides. So for example, if you subscribe to the newsletter, they will tell you that, we have brought new data on anxiety. So about 2-3 weeks ago, anxiety was not a theme that they were covering, but now they have provided it. So you can now have up-to-date slides on anxiety. So these are the, I take the credit as the PI, but these are the 4 people who came up with the idea. And I just support them. And these are going to be your trainees for the next 6 weeks. So for the next 6 weeks, our plan is every 3 days, 1 hour, we give you key contents on across disorders in psychiatry. And then you will use the resources on your own to have broader insights. And I think this is my last slide, and this is the most important slide, because and I'm going to just stop sharing here and go to the web page quickly. So if you could go to neurotorium.org, and I'll stop sharing, and I'm just going to show you some of the resources. So this is what happens when you go to neurotorium.org. Oh, where is it? I don't know, I keep clicking something and it disappears. And this is the landing page where you land. If you notice up here, there's anxiety, depression, Parkinson's, bipolar, stroke, Alzheimer's, all themes. One of the things I want to talk about is this 3D brain atlas. For people who are doing neuroanatomy, this is like a godsend, because it allows you to actually study the brain while you can visualize it. I remember when I was studying neuroanatomy, one of the things I used to struggle with is that I had to keep going to get a real human brain. But with the 3D atlas, you can, maybe I won't take too much time on it, but the 3D atlas allows you to visualize different aspects of the brain as you study. So it can, so for example, if I click here, cerebral cortex, it will show me this is the premotor cortex, this is the postcentral gyrus, and then it will give me, I can take a screenshot, I can get notes about the premotor cortex, I can get literature to read, you know. So it's a simple way to understand the brain. But for the next 6 weeks, what we'll be doing is we'll be really rotating around these key themes: anxiety, bipolar, substance use and addiction, Parkinson's. We're going to go through depression over the next week, but I just wanted to highlight, because you may think that what we are going to talk about, we are going to show you over the next 3 days, but that's not true. So for example, there is a section on definitions and diagnosis, epidemiology, neurobiology. All of this is for depression: cause, comorbidity, treatment principles. And then when you click, let's say, for example, definitions and diagnosis, you then find that there are 51 slides, a lot of information about just the definition and diagnosis of major depressive disorder. Now, because we are doing 1 hour a day, we are not going to try and show you all the 51 slides. The idea is that the trainees are going to tell you the important things, but you must go back and using the slides and using other texts to understand major depressive disorder. So if you think about it, 51 slides of just definitions and diagnosis of MDD, I think there are about 26 of the epidemiology, Here you can download a particular slide, or you can download all the slides. And if you notice, this was released 23rd of May, so it's quite current data. So I would just like to encourage you. We'll start on time, finish on time. We're not going to tell you everything that is in the slides. You will have to go and look at the slides yourself and read, and it's a wonderful resource. Again, I also encourage you to respond to the polls, because we are trying to scale this up and make it better. I must also acknowledge that there's another grant by Professor Catherine Abo that's looking at child and adolescent mental health. And so there are massive resources that we can use in Neurotorium, and we hope we will be able to use them. I'll stop here for now, and I'll hand over to Dr. Katama.
Thank you so much, Dr. Mwesiga, for that brief yet clear introduction you have given us. Allow me to invite Dr. Sadat Katama. Dr. Sadat Katama is a newly minted psychiatrist, and as earlier noted, is one of our very own Neurotorium trainees. Dr. Katama, as I'm inviting you, I request you to be sharing your slides. So he's a familiar face to many of us, a well-known and respected colleague who truly needs no introduction. Dr. Katama, please take us away into the fascinating realm of depression. Thank you.
Thank you, Dr. Muyanga, and thank you, Dr. Mwesiga, for taking the lead on this whole project of Neurotorium peer-led training. So today, I am Sadat Katama, and like Dr. Muyanga has introduced me, I don't wish to add much to that. So today we are going to look at this week we are looking at depression, basically major depressive disorder, and this presentation is going to be in 3 categories. So today we are looking at the definitions, the diagnosis, as well as the natural cause of this disorder. And then tomorrow we shall look at the etiology, the neurobiology, basically to understand the neuroscience then. And we shall also look at how common this condition is, in which categories, basically looking at its epidemiology. And then on Thursday, we shall wind up with the treatment principles. The treatment alone is given a full day because we really need to understand very well how to go ahead with managing the patients. And also, for those who are here and they are not particularly clinicians, but probably they have colleagues or they have had some of the symptoms or the things that we shall be talking about, it will give ideas on where to seek help or how to approach this condition called major depressive disorder. So allow me kick off by starting just briefly mentioning about the history of depression. Well, today we have what we call the criteria upon which we diagnose major depression. However, back in that day, these symptoms have been described. For example, Hippocrates he described something he called melancholia, which he described as the fear or sadness that lasts a long time. And this included symptoms of aversion to food, sleeplessness, irritability, restlessness. And we are going to find some of these things that he described in what we are going to look at today. It is in the recent era when we look at the DSM, the ICD, where this condition, major depressive disorder, has been described fully, and specific criteria have been proposed to give the diagnosis and also guide the treatment of this condition. So what is this thing called depression? Time and again, people can feel low, or they feel sad, or they feel they are just there. And when someone is broke, it's quite common for someone to say, oh, I'm depressed. But to us, as mental health professionals, depression is beyond just that feeling you get just because you're broke for a day or two. It is a very broad and heterogeneous condition, and it is basically, we describe it based on the specific criteria that I've mentioned, the WHO, ICD-11, and also the American Psychiatric Association's DSM-5 systems. So it basically talks about the symptoms being present for at least 2 weeks and then impairing someone's function. And these symptoms, we are going to look at them in more detail. We shall see which specific symptoms are supposed to be there. And if you look at them, when do you say that, maybe I have depression? And if it is depression, which kind of depression that someone could actually be having? Depression is basically a remitting and relapsing condition. Symptoms can persist between episodes. They might remit, they go down, and then they recur. So all of this happens within depression. It is important that our interventions target complete remission of symptoms, where all symptoms have been cleared and the person is able to live a productive life. So particularly the major depressive disorder, this is the key disorder within these depressive conditions, and it is characterized by that discrete episodes of at least 2 weeks duration. These episodes should last a minimum of 2 weeks, though they can go for a longer duration, and they have clear-cut changes. The key presentations is within the affect or the mood, the feeling of someone, then the cognition, how they think, and also the neurovegetative functions, and then of course those different inter-episode remissions. The key features are the presence of sadness, the empty or irritable mood, especially in children and adolescents. You find that irritable mood is the most common one, that it happens a lot with the children. And then of course there is a loss of interest and the capacity to feel pleasure even in things that someone actually felt was enjoyable to them. Then of course we have the other symptoms that we shall be describing. So the diagnosis is based on a single episode. Once someone has these symptoms for 2 weeks continuous, then we can say that this is a major depressive disorder. Although you can have those recurrent episodes which may be full as this one or may be subsyndromal. So depression has has so many symptoms and they vary. You'll find those on the physical spectrum, then the emotional, and then the cognitive. So on the physical side, you're going to find headaches, pain, physical health concerns, and this is usually what leads to people ending up with a general practitioner, and they say, I feel body weakness, I feel muscle aches, I feel headaches, and they will be assessed for things like malaria, brucella, but they find that nothing is there, and they end up giving probably unnecessary treatment. It's not until things like insomnia or hypersomnia come in that probably they start thinking, oh, maybe this could be something else. Then, of course, on the emotional side, this one is quite clear, especially when you find a suicidal ideation where someone is brought to hospital either because they are talking, they want to kill themselves, or they have even attempted to kill themselves. This is what usually raises suspicion, and then they'll be like, oh, let's call the psychiatrist to assess this patient. Then, of course, the sadness, the anxiety, all these symptoms are usually there. Then on the cognitive side, there is usually the loss of motivation, and also particularly on the attention and concentration. You find that someone's work is going down slowly, performance at school is going down, while everyone thinks, that one is just maybe not serious, yet it could be just depression that is leading to that because of the poor concentration, the memory difficulties that can come with it. Now, these symptoms have a great impact on the patients. First of all, on the personal or family life, you find that there are those relationships within the family or within the person themselves where they feel that these things become impaired. The person is unable to participate fully in family life. Someone finds it difficult to attend to particular activities within the home or even for themselves. Someone finds it very difficult to even say, let me take a shower. They just feel like they don't have the energy to. And then, of course, there is the work school or school environment where there is loss of focus. Someone is always asking for sick leave, so they tend to be sick all the time. Then productivity goes down because this person is no longer working efficiently as they would or they should. They end up, you find that their results are going low. Then, of course, the social life is also affected, where I find this person finds it difficult to form or to participate within social gatherings. There is social exclusion and isolation. So the interpersonal relationships actually do go down. Now, when we talk about major depressive disorder, we always describe these symptoms here. There are 9 according to the DSM-5. These 9 symptoms, usually we just say depressed mood, loss of interest. However, this table here provides us with a better way to understand when we say depressed mood, what exactly do we mean? You're going to find that when we say depressed mood, we are describing the patient's mood, where they say they are depressed, they are sad, they are discouraged, they feel down in the dumps, they feel blue, and or people describing that they don't have any feelings. Then this should vary according to the day or even the circumstances. Now, this depressed mood does not particularly elevate or get better with change of situation. Someone has been feeling sad that even when they get money, they don't feel any better. They just remain within that state. And yet probably people are thinking that's because he's broke. But then you find that even when they get the money, the situation does not change. Then when we say loss of interest, this table goes ahead and describes, particularly someone had hobbies, someone had things they used to love to do, but then they reach a point where they do not care anymore. They just don't find enjoyment in any of these those things that they used to find pleasure. Now, the DSM-5 describes these different 9 symptoms, and of particular importance, I need to mention about this one of thoughts of death or suicide. Someone can have those recurrent thoughts of death, wishing they should just sleep and not wake up, wishing that if they are walking and maybe a car knocks them and they die, to points where they actually go ahead and act on these thoughts. They decide to maybe slice their wrists or throw themselves in the water so they can drown. And this is very, very important. It is one of the reasons that many patients are actually sent in for assessment. Because these other things, most of the time, they don't interfere with others' well-being. People see them as that person's personality is just changing. But when we get to suicide, that's where people actually find it important to refer for care. Now, for us to diagnose major depressive disorder, you find that we need a minimum of 5 of the 9 symptoms. However, at least one of those 5 symptoms must be the depressed mood or the loss of interest or pleasure. So when you find there is a depressed mood for most of the day, based on the report of the patient or those who always stay with the patient, those who observe the patient, then you add 4 other symptoms of all these 9, and then that is when you will say probably this person has major depressive disorder. Then we need these 5 symptoms to be accompanied by a clinically significant distress or impairment. Someone's work is affected. Someone's education is affected. someone whose family is affected, like their relationships are affected. This, together with the symptoms, should then raise the suspicion that probably this is depression. And then, of course, we must rule out any other possible causes of this depression. When you look at things like hypothyroidism, or maybe the effects of a substance or a medication that someone might be using. Someone might be using alcohol a lot and they're always there. Then people be like, this one is depressed, when it is just the effect of the substance that they are using. So when you get the 5 symptoms, together with the impairment in function, and then you rule out any other possible cause, then you say you have a major depressive disorder. Now, this we shall look at it again when we are looking at treatment, so that we see how these symptoms change across the time when the patient is being treated. So there is always a point. There's always a point where someone has no depression, but then they start getting the symptoms through which they progress to the syndrome, to the disorder down here. Now, when you cross this line here and go down, as the symptoms increase or the severity of the symptoms increases, you find that the severity of the illness increases. Then we find them at this point, which we call the acute phase, where they have the active symptoms. And when we start them on treatment, you find that the symptoms start reverting and they go towards the side with no depression. All along this line, you can find that at any one point, the symptoms can recur, they can worsen, where someone can have either a relapse or a recurrence. We shall talk more about this when we are looking at the treatment. Now, like I said in the beginning, major depressive disorder is very complex. It is a recurrent and often remitting disorder. You find that with or without treatment, it can actually, this is a mood problem, it can improve. However, if someone is not successfully treated, you find that the chances of the symptoms recurring increase. So with the initial episode that someone gets, up to 50% of people actually recover with no further episodes. However, 35% often experience recurrent major depressive disorder, like they keep getting episodes of this illness. And about 15% actually experience the unremitting disorder, maybe because of misdiagnosis, maybe because they are not getting the right treatment, maybe because a certain element of their social life or their psychosocial life has not been considered, and then this can lead to this unremitting major depressive disorder. So the risk of relapse usually decreases if the person's recovery duration increases. So when you look at this graph, you're going to see that here we have the survival distribution function, and you're looking at the asymptomatic recovery, those people who recover without any symptoms, that is this upper curve here, and then those with the residual subsyndromal depressive symptoms, whereby even with the treatment, they have some symptoms. So you find that the survival distribution, you look at the survival of this one, is very low if people have residual symptoms compared to those without any residual symptoms. Of course, you look at the median weeks when someone is well. For the asymptomatic, it is about 231 weeks, while for those with residual symptoms, it is 68. This underscores the role of treatment with the goal of having residual symptoms. Now, the diagnosis, like I said, when you look at the DSM-5, and I also talked about the ICD-11, the same symptoms exist across both systems of diagnosis, but of course there are some differences. For example, in the ICD-11, you don't have things like self-esteem problems or self-confidence. These are usually in the explanatory notes within the DSM-5. Now, when you diagnose depression, it's very important to rate this patient's depression. At what level is the severity of this condition? You need to know. If you find that the person has fewer than 5 symptoms, maybe they have sub-threshold depressive symptoms, so they don't meet the full criteria for a major depressive, maybe episode or major depressive disorder. But if you find that you're using a particular rating tool, I'm going to give a summary of some of the rating scales that we can use for either diagnosis or rating the severity and monitoring treatment of depression. So if you find that if you're using, for example, the Montgomery Asberg depression rating scale, you're going to find that if someone scores between 9 and 17 symptoms, then you say this is mild depression. So below this, then you know someone is looking at the sub-threshold depressive symptoms. Then the moderate depression will be between 18 to 34, and then 35 to 60 is where you have severe depression. Now, the treatment choice is going to depend on the severity of this of the depression. So it is important that when you get a patient, you assess them, you rate them with a particular tool upon which you're going to base to provide the appropriate treatment. There are structured interviews that can help in the diagnosis of major depressive disorder. We have the mini international neuropsychiatric interview, which is based on the DSM-5. Then we have the SCID, we have the scan. All of these, you can look at this slide down here. We have the different references of where these can be found, and then you can look at them, how they can be used, and how long each takes in order to diagnose depression. In the differential diagnosis of depression, you're going to find that so many conditions actually might present like major depressive disorder. Someone who is bereaving can actually present with psychological, or maybe there is something, maybe they've lost a relative, and then they are sad, they are crying, they don't want to do anything. It should not be confused with depression. And when you look at the DSM-5, it clearly gives a clear distinction between DSM-5, between depression and then between grief. Then there is the persistent depressive disorder, whereby someone's symptoms last for 2 years or more. Basically, the symptoms do not completely go away. They just subside and then come back for a period of 2 years or more. Then you'll have, of course, where you have a major depressive episode happening with other symptoms, which might be manic or hypomanic, in which case the patient will be diagnosed with either bipolar 1 or bipolar 2, depending on the presentation, as well as other conditions. Then you have the premenstrual dysphoric disorder. This one, usually the symptoms come just before menstruation and then they resolve after menstruation. That one just shows you that you're dealing with premenstrual dysphoric disorder. So this one is in women, obviously. This slide is just looking more about the persistent depressive disorder, how it lasts in adults over 2 years or more, while in children it is over 1 year, and then the different symptoms that should be accompanied. Then, of course, we have these other specified depressive disorders, and the DSM-5 describes them. I request that since we have the access to these slides, we can actually go ahead and get access to these slides. We download them, we can read them to understand them. We can even read the citations, the sources, the research that has been done where they are citing this information. Then we have these other differential diagnoses. Major depression might be mistaken or might be happening along these other lines. Someone can have manic episodes in which you're going to have maybe bipolar. Then someone might be just having a mood disorder due to a general medical condition. Someone has hypothyroidism and they come with those symptoms clear of depression. When you treat the hypothyroidism, these symptoms also resolve. Then substance use, as I talked about. ADHD might present because of the distractibility, the low frustration tolerance. You find that someone might have some symptoms which some people might think probably, but it is always clear if you take good history, And then, of course, you use those rating scales to determine whether you're dealing with depression or something else. Then, of course, there is adjustment disorder. Then sadness. I mean, it is very normal for someone to feel sad. Probably they've lost a phone, or they've lost something, or they just feel don't feel, they just do not feel good at that time. However, this should not be nearly every day, most of the day, for at least 2 weeks, and whereby you're having 5 particular symptoms with the depressed mood or the loss of interest, as well as the significant impairment in function. Then we have the different specifiers. I've talked about the mild, moderate, and severe specifier. Then you can have whether it is a single episode, someone has come and this is the only episode they have, it is the first and it's the only episode, or they can have recurrent episodes. They have had episodes before. Then someone can be either in partial remission or full remission. With partial remission, someone whose symptoms have gone down, but some symptoms still remain. Or there is a period lasting less than 2 months without any particular significant symptoms of depression. While in full remission, you find that 2 months or more, there are no significant signs or symptoms of the disturbance that were present initially. Then we have these other specifiers where I find with anxious distress, with mixed features, like I talked about, those manic or hypomanic symptoms that might come along. Then DSM-5 goes ahead and talks about with melancholic features, atypical features. These ones I encourage us to go and read more into most of these. Then, of course, those with psychotic features, this is usually why people are sent. If it is not because of the suicidal ideation, it is because of the psychotic features. Because someone is now behaving unusually, or is maybe seeing or hearing things, and then they say, did you talk to me? And someone has not talked to them. It disturbs others, and then they be like, oh, we need to maybe have this person assessed. Then, of course, there is with catatonia. I think we've ever had a presentation on catatonia in our UAP sessions, or CME sessions monthly. So this can also happen in depression. Then of particular importance, there is this one with peripartum onset. So this is now the specifier in pregnancy and following delivery, where someone meets a major depressive episode, the criteria, but it has started in pregnancy or after delivery, usually up to around 1 year post-delivery. Then, of course, there is that which changes with the season. Someone in, probably it is winter period, and then someone becomes depressed. When the winter goes, the depression goes out. So there is also that depression with seasonal patterns. Now, most of the things I've been talking about are from the DSM-5. The ICD-11 doesn't change so much. You find that you need at least one of these 2 symptoms: persistent sadness or low mood, or the loss of interest or pleasure. So when one of those is there, you have to ask for these other symptoms. And then when you have more of these, 4 of these other symptoms together with this one, you go ahead and find out where the person lies. The severity, you need to rate the severity of the depression, because this is going to guide your management. Commonly, the screening instruments that we use, we have the Hamilton Depression Rating Scale. This one takes about 15 to 20 minutes, and it is clinician administered. So here, if it is you, the clinician, you have a patient, you have then to give this to, you have to subject the patient to this, so that you can know the level of the severity of this patient. And down here, it gives the different, down here it gives the scores, and then the different severity levels: 0 to 7, 8 to 13, 14 to 18, like that. So when you find these, when you assess your patient and then you rate where the patient lies, this then informs your management plan. Then we have the Montgomery-Åsberg Depression Rating Scale. It is rated between 0 and 60, also takes about 15 to 20 minutes. This one is also clinician administered. And I already gave the severity levels for this one. Then, of course, for children, we have the Children Depression Rating Scale. revised. This one takes 30 to 40 minutes, still clinician administered. Of course, we have the mini kit, which can also be used to assess for depression in these children. Then we have those rating scales which can be self-administered. The patient can get it, they take out, and they get the total, and then they see where they lie. So this one is the Beck Depression Inventory. It's a 21-item scale, and it also gives the different scores for the sub-syndromal, then the sub-threshold depressive symptoms, and then mild, moderate, and severe, very severe depression. This one is very easy to use. Takes about 5 to 10 minutes, depending on the ability of the individual. There is the GDS, the Geriatric Depression Scale. This one often tends to be used for the elderly, and it is good when you're having patients whom you are wondering, could this one be having a dementia? Is this depression? What is going on exactly? Or they have another chronic condition and you need to be sure that they don't have depression as well. You subject them to this. And then, of course, the SSD, this one is mostly used in the general population. So it is more used for large-scale population surveys. The PQ9 is very commonly used, and these are its cutoff scores on how to rate the depression level. This is also self-reported. Then there is the GBI 10D. It can also be used. It takes about 5 minutes. Now, when you look at this table, it is giving these different scales and the different cutoffs with the severity levels. I'm not going to go into this because we've been seeing most of this. I have already talked about this. We shall talk more about this figure here when we are looking at the treatment. When do you have to continue? For how long do you have to continue? For how long do you have to maintain the individual on treatment? And if it is you who is the patient, for how long do you have to keep on that treatment? So that if your clinician is telling you, I'll only treat you for 3 weeks, you should be able to say, no, according to the something that I had, it is supposed to be probably for this kind of period of time. Now, why was I talking about the measurement, the scoring, or the rating of the severity of the patient? When you look at this graph, a study looked at the number of patients, the proportion of patients who had full remission and those without full remission. And it was basically looking at those who got standard treatment, whereby they were just receiving treatment without monitoring their symptoms with a scale, and then those who had what we call the measurement-based care. In measurement-based care, you find that a patient is diagnosed, then they are rated with a particular scale, like we have seen, and then based on that scale, decisions are made in terms of the treatment choice and the duration. And then the effectiveness of the treatment is monitored based on the scores. If the scores are going down, you know your treatment is working. If you find that the scores are not going down, then you have to wonder about your choice of treatment or the adherence to the treatment. So you find that the proportion of patients without remission, so those people whose symptoms persisted, if you just do standard care without monitoring the patient's symptoms, up to almost 70%, their symptoms do not remit. While when you use measurement-based care, only about 20% have their symptoms not remitting with a particular course of treatment. So this underscores the role of rating our patients, determining the level of severity of the illness, and throughout treatment, monitoring to see the response to the treatment. I have talked about how depression can actually impact someone's life, the social life, the work, the family, and the person themselves. When you look at this graph, this study looked at the proportion of patients, or the percentage of patients who had residual symptoms and those without residual symptoms in terms of being able to fulfill these particular aspects of their life: work, marriage, and then parenting. Now you find that when you look at work and then marriage,
Dr.
people
Katama,
whose, yes,
yes, we should be summarizing.
yes, please, thank you. So when you look at this, you're going to find that almost twice for those patients who received complete remission, when someone gets complete remission, all symptoms are gone, you find that there up to 81% of those individuals are able to work. While those who still have residual symptoms, only 42% are able to work productively. The same thing happens when you look at marriage. However, when you look at parenting, still even those with whose symptoms have just reduced, but they have some symptoms still present, their parenting is still high, but still you find that those with complete remission are doing better. So this should call for us to ensure that we target complete remission of the symptoms. Depression can have interactions with physical health. It can lead to physical health complications, while physical health problems can also actually lead to depression. So tomorrow we shall be looking at the interplay between all these things in leading to depression: the HP axis, inflammation, the gut microbiome, all of these things. We are going to look at them tomorrow when we are looking at the etiology and the neurobiology of depression. When you look at people, this study looked at people who reported that their symptoms had remitted. Those people compared with those who reported that their symptoms had not remitted. So people whose symptoms had not remitted are these ones here. This is self-report. You find that their levels of anxiety and the severity of their symptoms was way higher compared to those whose symptoms had remitted. So still this underscores the goal of ensuring that all symptoms, that the target of the management in depression is to have all symptoms remit. In summary, this is what basically we've been talking about. Depression is a heterogeneous condition with a very broad range of symptoms, and it has different variations as we have described. Diagnosis, we should be based on the DSM-5 or the ICD-11, and then we need to rate the severity of the illness so that we target our treatments for particular outcomes so that we monitor the patients. Thank you very much for listening.
Wow. Thank you so much, Dr. Katama, for that insightful discussion you had. You had a lot to share, but you've still managed to set the tone beautifully for the rest of the series. And you've reminded us why understanding neuroscience behind these conditions actually matters within the clinical context. Allow me to quickly take a moment to recognize and appreciate the presence of several seniors. I've seen Dr. Kalani Kenneth somewhere, Dr. Molina Isanga, Dr. Emmanuel Pamizo, and others who are present. We thank you so much for joining and supporting this learning space. At this point, we'd like to open the floor for questions and reflections. And Dr. Katam, actually, we already have a number of questions within the chat. But in case you're unable to type in the chat, please put up your hand and we shall give you permission to unmute. However, before I read for you, Dr. Katama, the first question, allow me to extend a special thank you to Dr. Muwanguzi Moses and Dr. Lillian Nagwire for making this engagement possible. Your behind-scenes work and coordination have been truly appreciated. This wouldn't be possible without you. So the first question, Dr. Katama, is someone, that is Deborah Nabukalu, is saying the scales seem to be very many. Aren't there cases where what is major in one is taken as minor in the other? I think she's talking about conditions in this case, probably.
Yes, thank you for that question. So the scales are many, yes, but you see, because of the variability within the presentations of these conditions and also the different places where these scales are developed and even the different timelines when these scales were developed, a lot has been changing. Studies are done, of course, to look at the correlation between the agreement within these scales. And you find that when you look at, for example, the BDI, the Beck's Depression Inventory, and then the Hamilton, the HAMD, or you look at the Montgomery, Asberg, you find that their scoring doesn't vary so much. But if you're going to monitor a patient, for example, and you choose to use a scale, it is better that you use that scale throughout the management. I mean, it doesn't make sense for you to use the PHQ-9 to start the treatment. Then when you're monitoring after maybe 2 months, you want to know how the patient is doing, 1 month or 2 weeks, and then you use the Montgomery. That will not make sense because your rating was based on the PHQ-9 when you were starting the treatment. So you should use that for monitoring your response to treatment. So when you choose to use a scale for a particular patient, I think it is better that you use that particular scale.
And thank you so much. And Solomon is asking, is there any proposed explanation why depressive symptoms remit better when rating scales are used? That was, he noted that at around slide 40, I think.
Yes. Thank you, Solomon. So when using these rating scales to determine whether looking at an explanation for the remission of these symptoms, if a patient comes to you and they have maybe 5 of the 9 symptoms and you say they have depression and you just give them treatment, they go home, and then maybe they come back for review and you ask them, how are you feeling now? And they just tell you one of these symptoms has gone or two, or all of them. When you look at those rating scales, you find that their scores are not just based on the 9 symptoms. There are other aspects that they actually put into consideration. Those aspects are very important in ensuring that the patient is actually recovering, because they affect the life of this individual. They can either worsen the situation or they can improve the condition. So using these scales ensures that you know that if a person has come in today and they are scoring a certain cut of a certain level, and then you give them treatment, the idea is that if your treatment is working, then the score they scored should go down. Should you find that the scores are not going down, either they are maintained or they are increasing, then you should worry about your treatment that you're giving, or the adherence to this treatment, or the impact of this treatment for this individual. So basically, it is guiding you on whether you're doing the right thing as far as the management is concerned, by monitoring how those symptoms are changing over time. Thank you.
Thank you, Dr. Katama. And then there's another question from Mr. Mwanguzi. Emmanuel, he's saying, thanks for the presentation. Could there be any determinants to choose a particular scale, or are they country-based?
Any determinants to choose a particular scale? So, of course, within our setting here, we have the challenge that we do not have so many scales that have been designed for us. I think for depression, I know of the Akena Visual Depression Inventory, which is actually helpful even for people who can't read. That for them, they look at the picture. If you ask them, how do you feel in terms of this? If it is about sleep, they can point that this is how I feel when it is sleeping. And then you rate them and you go ahead and say, oh, this is, maybe they have depression or not. But because we do not have so many of these that have been developed in our setting, then this rests upon your ingenuity to know that I should use this, maybe this is what you're well conversant with. Or you've looked at the sensitivity of a particular scale, and then you choose to use that scale because probably it has shown that in similar settings, it actually picks out depression, and it has been used for monitoring treatment.
Yes, thank you so much, Dr. Katama. Thank you. I think that is clear. So Dr. Diana Among is asking, saying, thank you, Dr. Katama. What is the prognosis of depression in those with childhood, with adverse childhood events?
All right. Thank you, Diana, for that question. So when we are looking at the treatment principles on Friday, I think this question is going to be answered more fully at that time. Because when you're managing this patient, the prognosis basically is going to depend also on your intervention, and your management is going to base on your assessment and also the risks that the person actually has. So when you look at the predisposing factors, the precipitating and perpetuating factors, you are going to use to base upon those to target your intervention. Where you're going to use medications, where you're going to involve psychotherapy, and then the social management plans. These are going to be talked about when we deal with treatment principles on Thursday. So I beg that we talk about that on Thursday, Dr. Monk. Thank you.
Certainly, Dr. Katama, we respect that and we look forward to that discussion. So Dr. Mwanguzi Moses is going to launch a poll, which we humbly request you to fill in as we continue with the questions. And as we are concluding with this session, certainly, this is a quick reminder that tomorrow at the same time, we're actually going to be getting into the real meat of the discussion, and that is the etiology, the neurobiology, and the cause of depression. It's going to be a deep and really fascinating session, so please do not miss. This has been just the introduction into the world of depression. Okay, I think we can all see the poll is there, so kindly help us to fill in that poll. Dr. Brian Wesige, this goes to you, Dr. Katama, as we fill in the poll. He's asking here that, is there a clear neuroscientific basis for depression resistance? Okay, Brian, you want to kill someone, but this is nice. Bring in the hard questions.
Yes, thank you, Brian, for this question. So tomorrow we are going to look at the neuroscience, basically the neurobiology. How does this depression come about? And then when we look at the treatment principles, we shall also talk about treatment-resistant depression in particular. And then we are going to understand at that time to merge whatever happens in the neuroscience leading to the resistant depression. I beg that also this question, we answer it after understanding the neurobiology of this depression. Thank you.
Thank you, Dr. Katama. Dr. Brian Wesige, by the way, is a psychiatry resident in Barara. So I'm not surprised that he wants to take us into the neurobiology and so on. He's eager to take that. We hope you'll satisfy that tomorrow. If there are any other questions, we welcome them. We are committed to ensuring that this session is strictly a 1-hour session, and our time is almost up. So we thank you so much for having joined this discussion. Tomorrow, same time, same link, please join us and we have this discussion. Thank you, ladies and gentlemen. Have a lovely night.